And a great pleasure. I have a good friend, and as I mentioned in my little blurbs, one of the leaders, if not the leader of patient blood management in the world, next to me. And we're fortunate to do this live from Johannesburg. We're sitting here at the Inanda Club, thanks to Chris Cassianidis' kind organization. Thank you, Chris. And really, really great pleasure. But before I introduce Prof. Hofmann, our guest, I just want to welcome all of you. It's lovely to see people from all over Sub-Saharan Africa here, as usual. And I've seen people as far away as Cameroon. Welcome, Prof. Chuten. And want to remind all of you that this meeting is organized by GastroEcho, G-Echo, hosted by the Gastro Foundation in association with Project Echo from the University of New Mexico. These meetings are held every Wednesday, and every Wednesday there's a different topic which varies from hepatology to pathology, endoscopy, etc. And every 6 to 8 weeks we are fortunate to have a patient blood management session. So I would like to really encourage you to use the chat box for questions, and as you think of them, please put them in the chat box, and we will have a time for discussion at the end. So with that, it's my great pleasure to now introduce Prof. Axel Hofmann, who's become a good friend. I think we first met about 7, 8, or is it 9 years ago now? Might be 2015 even.
Time flies.
In Cape Town, where I was first introduced, to my own shame, to patient blood management. I did not know what this was about, but I was invited to give a talk there on iron, but only to find out that patient blood management was actually a thing on its own. It was not just how to manage inventories of blood in a transfusion service. It was something completely different. And yeah, my mind was blown. And since then, I've become very, very passionate about this topic because I've seen the impact on patients. Now, Prof. Hofmann has got a very interesting background in that he's got degrees and PhDs and all sorts of things in medical science and also in health economics. And he's been a key partner in the main article, main publication that many of you are well aware of in Western Australia, where they showed how patient outcomes could be improved while at the same time saving blood and saving costs, which placed patient blood management right at the forefront as a way in which to improve outcomes, save money, that golden quadrant in health economics, which I'm sure Prof. Hofmann will share with us about.
No economics, almost no today, but anyway.
Little economics, okay, well, we'll see. But we're looking forward. Axel, welcome here. It's lovely to have you in South Africa. Both of us are speaking at the All Africa Anesthesia Conference tomorrow. Axel already spoke there yesterday. And we really look forward to your talk and see how patient blood management can really make a difference in global blood health. And with that, I hand over to you.
Thank you, dear Vernon, and thank you, Chris, for inviting me, the Gastro Foundation and the GI Hepatology Echo of Sub-Saharan Africa. I also looked at the list of participants and I see a few very familiar names. If I glance over it, so I greet you personally, Petro Lees, Marius Kotze, also Shahrukh, and I guess probably some other, Freddy Kabambi, I think, is here. So great to be with you and great to be back in South Africa. So let me start with my presentation. The title is, just one sec, I have to clear everything. So can you see my slides?
Yes, we can.
Okay. So, patient blood management to improve blood health globally. I'd like to show you briefly my disclaimer. I'm working with governments and public institutions, blood services, professional societies, NGOs, and I'm supported, not always, most of the time even not supported by the industry, however, a little bit. And I want to go back to the 17th century to William Harvey. He was ranking organ systems in a hierarchy as to which was vital to maintain life. And ultimately, he viewed the blood as the supreme organ and that the heart existed to support the blood. In other words, the vital driving the mechanical rather than the reverse. Now, if you look at the circulatory system, we have the heart, we have the blood vessels, and we have the blood. And who looks after these elements or organs or systems? Well, primary care physicians, cardiologists, cardiac surgeons, cardiac anesthetists look after the heart, an even larger group after the blood vessels. But who looks after the blood? And sorry to say, Vernon, but I think not you, but most of your colleagues around the world, they primarily look after malignancies and rare blood disorders. But here is a huge cohort of 2.9 billion individuals that either suffers from anemia and or micronutrient deficiencies, plus another 600 plus million with chronic or acute blood loss and or bleeding disorders. And if you look at these sheer numbers, we come to the conclusion that probably the blood is not something that gets the attention it should have. In fact, the WHO sees the unmet need to manage and preserve the patient's own blood. And this is not good, because if we look at blood facts, here are a few. In concert with the cardiovascular and lymphatic systems, blood serves as the infrastructure of the body's physiology, integral to the functionality of individual cells and the integrity of all organ systems. So important. With its cellular and liquid components, it maintains inseparable connections with the cardiovascular and immune system, interacting within vascular networks that are unique to each of the body's organ systems. And of course, it ensures the continuous flow of oxygen, nutrients, hormones, as well as the integrity and protection of the body, including the coagulation system. And we should keep in mind that all medical disciplines, almost all, probably not psychiatry, leverage the blood to interrogate their organ of interest. And there's hundreds and hundreds of essays. And the first thing you are undergoing when you enter a hospital is a phlebotomy and a blood test. So as the blood contributes to the health of all the other organs, it is imperative to recognize blood health as a concept unto itself. Blood health is defined, and this is a publication in submission, as the optimal function of individual elements of blood and their associated interactions with all other organs and organ systems. Not caring for blood health is associated with reduced quality of life, increased morbidity, mortality, and other unintended consequences. I just want to zoom in from this large cohort into the cohort of those who are anemic within the 300 plus million major surgeries. And these are all data from Weiser and Rose in around 2010 or so. Meanwhile, we might have probably 400 to 450 million major surgeries, and about 1/3 of these patients is anemic, a little bit more even. So the prevalence, depending on the subpopulation of anemia and iron deficiency, or the A problem, is somewhere between 20 and 75%. And then blood loss and coagulopathy with bleeding is another 6 to 12%. In cardiac surgery, it is higher. And these three factors, the A, the B, and the C problem, as I refer to them, are the triad of, or form the triad of independent risk factors for morbidity and mortality. Now, a quick look at the impact of anemia. Here's a large retrospective cohort study from Musalam and colleagues looking at pre-op anemia and post-op outcomes in non-cardiac surgery. What you have here is the figure, the 30-day mortality by anemia and risk factor status. And you see the purple gives you when the patient is both negative and not anemic and has not that specific risk factor. Then the opaque is anemia negative, but the risk factor is present. And then the blue is anemia positive and the risk factor positive. And you see that anemia seems to multiply all mortality in these patients with several conditions underlying. The same is the case for composite morbidity. Like here, systemic sepsis, for instance, is almost a threefold increase with the anemia compared to the same patient with no anemia. Or here, meta-analysis of the association between pre-op anemia and mortality after surgery with almost 1 million patients, of which 39% out of 24 studies were anemic, and the anemia was associated with an almost threefold increase in mortality, fourfold in acute kidney injury, twice as many nosocomial infections, and a subpopulation of cardiac surgery patients. Stroke was up by 28%, and it's a main driver for red cell transfusion. A similar picture here in women prior to gynecologic surgery, with their increased risk of complications after their surgery. Again, mortality 2.4 times higher, and you see at the end of the scale a major driver for red cell transfusions. And we should not forget that 50 to 70% of females present for gynae surgery in a status of anemia. And just to show you the sheer size of the problem in more detail, there's 2.9 billion broken down. General population has an anemia prevalence around 2 billion. Iron deficiency anemia alone is somewhere between 1.2 and 1.5 billion. And isolated iron deficiency is probably twice the number of anemia. And the clusters are neonates, children, women of the reproductive age, especially during pregnancy, and the elderly. And we know that anemia is associated with all sorts of unintended consequences. The macroeconomic dimension of the problem, when we measure it in years lived with disability, adds 8.8% of all conditions worldwide, just anemia. And it causes cognitive and productive gross domestic product losses of up to 4% of GDP. Then anemia of inflammation, which is the second most common form of anemia and often coexisting with iron deficiency anemia. Those attributable to infectious disease, it's a 12% prevalence. In the CKD population, between 100 and 450 million are likely to suffer from anemia. With cardiovascular disease, there are big numbers. Anemia as a comorbidity of chronic heart failure and diabetes affects at least 170 million people. Inflammatory bowel disease, somewhere between 36 and 90%. So again, it's huge, and it's overwhelming. Cancer-related anemia, patients with hematological and oncological malignancies, somewhere between 26 and 53%, and patients with solid tumors and chemotherapy, it might be as high as 75%. And if we think of the 19-20 million new cancer cases every year, this again adds to the overall picture of the spectrum of anemic patients. We spoke already about the pre-op and pre-procedural anemia and iron deficiency, then hospital-acquired anemia due to phlebotomy is a big problem. Marcel Levy once published that the annual blood loss due to phlebotomy is estimated about 25 million liters. This is about 50 million, the equivalent of about 50 million blood donations, which is again equivalent to half of the world's blood donations. And then we have this other big block, which is blood loss, heavy menstrual bleeding and uterine bleeding, perimenopausal and dysfunctional is clearly more than 400 million women. Then upper gastrointestinal bleeding, large prevalence, and the crude incidence of acute lower is somewhere of 87 per 100,000 populations. We didn't find more accurate data. Then acute blood loss due to trauma, severe hemorrhage associated with trauma is difficult to estimate, but road traffic accidents alone account for about 50 million cases. And then the big problem of PPH, 6% of all deliveries, which means 8.4 million events per annum, and severe cases of PPH are about 2.5 million events. And recent evidence suggests an association between low prepartum hemoglobin concentration and an increased risk of PPH. So this is where both anemia and blood loss come together and exacerbate the problem. Then coagulopathies with bleeding, what is probably not known, you know it, but probably not everyone. Van Willebrand disease is the most common with an estimated prevalence of up to 2.2%. And then acquired coagulopathies, a lot has to do, of course, with this raise of anticoagulants. You see here, like rivaroxaban or apixaban, and all these drugs are skyrocketing, and with them, acquired coagulopathies are increasing. And then finally, trauma-induced coagulopathies, TIC, in up to 15% of patients admitted with trauma. So this gives you the spectrum why we think patient blood management is so important. So you might say, well, we know that anemia, blood loss, coagulopathy with bleeding is common, and this is why we have transfusion. So why such a such a nervousness? Blood transfusion, in fact, is the most common procedure performed during hospitalizations, and it's in some countries at least still growing. And when we look at our triad again, we know that the default treatment is transfusion, not of course in all of these cases, only when it's critical. But if you look back into the history of blood transfusion, this is an instruction manual for surgery at Johns Hopkins in 1917. And in chapter 4, indications for transfusion, it says they are carried out where there are no true indications at all. Not always, but quite often. Or here, this article in the New England Journal of Medicine in 1936, titled The Use and Abuse of Blood Transfusions. Transfusion of blood may be a life-saving procedure under certain circumstances, but it's too often undertaken when the doctor can think of nothing else to do after all other therapy has failed. Or in the Lancet 1942 by Brigadier Whitby, there is now a very grave danger that the conveniences of the blood bank may sometimes, if not frequently, lead to the neglect of the therapeutic ideal. Now, what is happening nowadays? These are papers, recent papers, looking, this is in JAMA, the median lowest hemoglobin level on days with an RBC transfusion in ICUs ranged from 5.2 to 13.1 grams per deciliter across centers and 5.3 to 9.1 grams across countries. Inappropriate rates of transfusion up to 57%, platelet usage not concordant with guidelines. Critically ill are more likely to receive blood at night. Wide variations in blood product transfusion practices in patients with acute leukemia. Great variability of transfusion in pediatric surgery. And this is very sobering, a 17-fold difference in adjusted transfusion rates across surgeons and 13-fold difference in adjusted transfusion rates across hospitals. And this is so important because we know when we look at transfusion and outcomes, that transfusion is well, fraught with complications. Here is a study by Vic Ferraris with almost 1 million patients where they looked at surgical outcomes and transfusion just with minimal amounts of blood in the OR. And you can see here the dose-dependent increase of both mortality and composite morbidity. And of course, there might be many confounders. However, when they did the regression analysis with about 55 confounders, what stuck out the most was within the propensity score matching was transfusion as a leading mortality. And therefore, the authors conclude that intra-op transfusion of just 1 unit should be undertaken with caution based on this study. This is quite interesting from last year from the NESCIP database in the US, looking at about 2.1 million coronary artery bypass graft surgeries and isolated aortic valve replacements. And out of that cohort, about half of them had no transfusion. The other one was transfused. And of that half was just this quarter here, 206,000 patients that received just 1 unit. And what the investigators did, they made a propensity score matching between that group and matched patients out of this non-transfused cohort, and saw that just 1 unit was associated with a difference in mortality of 40%, stroke 40%, sternal wound infection 40%, and you can see here the other unintended outcomes. You might say, well, this is all observational data. What about our randomized controlled trials? Well, number one, we don't have too much or almost no randomized controlled trials that compare no transfusion with transfusion. We only have restrictive versus liberal. And my colleagues and I came to the conclusion that these trials are not testing the efficacy of transfusion because it's not versus a placebo or another intervention. It's just the testing of anemia tolerance of different levels with a subsequent transfusion. In other words, to what extent lowering the hemoglobin threshold for transfusion can be tolerated safely. And so again, Kevin Trentino, Shannon Farmer mainly did this amazing work, a systematic review and meta-analyses, a review of all reviews, if you like, an overview of systematic reviews. And what was the learning point, or what is the take-home message? Well, here you see on the y-axis all the systematic reviews, including different numbers of RCTs in each of them. And you see an overlap between the restrictive and the liberal groups. And so it's really not very helpful to get to the core of the issue. However, there was one study that stuck out because you can see there's a very distinct delta between the restrictive and the liberal. You see that white space is a delta of about 2.5 grams from 7 versus 9.5 grams. And that systematic review from Salpeter included the famous studies from Paul Hébert and Jacques Lacroix, both on ICU patients, adults, and children, and then the study from Villanueva in upper gastrointestinal bleeding. And what they saw from these studies with, again, this distinct delta, the restrictive group versus the liberal group had a 20% lower risk of total mortality, and also the in-house mortality was 26% lower, and other outcomes were significantly lower. The number needed to treat with a restrictive strategy to prevent 1 death was 33. So we are left now that transfusion is fraught with direct transfusion risk. We are very familiar with those for many, many years, for decades. Plus, we have seen this culture and behavior-driven risk of non-indicated transfusions. And now we have this body of evidence that shows us indirect transfusion risk. In fact, we have more than 50 large studies with more than 8 million patients across many different clinical settings that demonstrate morbidity, mortality, increase in a dose-dependent relationship for all labile blood components. And this is now also becoming a newly recognized medical legal problem. So here's some questions for critical reflection. Are transfusion really, are they etiology-specific indications for anemia, blood loss, and coagulopathy with bleeding? I think the answer is clear. Do they improve outcomes, including morbidity and mortality? We're not saying this in general, but are they doing this in the majority of patient populations? Are transfusion a cure? Are they safe? Are they not immunomodulatory, pro-inflammatory, and pro-thrombotic? Do they improve blood health? Are there no safer and more effective or cost-effective modalities? Here's the economics part for you. To treat anemia, blood loss, and coagulopathy with bleeding. If we go back to this consensus some years ago, where the appropriateness of red cell transfusion was in the focus, this was the first international consensus conference on that issue. The panel found that 59% are clearly inappropriate, and about 30% are uncertain, which means in the inappropriate sector here, it means nothing but harm to the patient and cost to the system. And this is in the absence of patient blood management. So coming back to our model here, we understand there is this triad, there's this default treatment, and we can now see that hundreds of millions of patients are exposed to one or more of these additive risk factors. And the problem is not really the transfusion. The problem is the omitted or incomplete etiology-specific diagnosis of these factors up here in the triad. The problem is that there is no management upstream in the patient journey. And this is the identification of healthcare's biggest patient safety gap when we look again at the sheer numbers that I have presented you earlier. Yesterday at the World Patient Safety Day, the topic was improving diagnosis for patient safety. And it spoke about diagnostic error. It spoke about delayed, incorrect, or missed diagnoses. And again, omission is a misdiagnosis. Here, again, is our problem. And the only way to reverse this is a timely and effective patient blood management looking at these risk factors, and then you minimize the need for transfusion that still has its place for some indications, of course. This is the new paradigm. And this is based on 3 pillars. Originally, they were developed for surgical patients. Pillar 1, detection and management of anemia and iron deficiency. Number 2, minimization of blood loss and optimization of coagulation. And finally, leveraging and optimizing the patient-specific physiological tolerance of anemia in extreme conditions. So the comprehensive medical model to achieve and maintain blood health is really managing upstream, meaning managing the patient's own blood. And that is where the definition aims at. Global definition that was that came out 2 years ago. PBM is a patient-centered, systematic, evidence-based approach to improve patient outcomes, or we would now add blood health, by managing and preserving a patient's own blood. At the same time, it promotes patient safety, the celebration of yesterday, and empowerment. And this is driven by a number of entities and now endorsed by a growing number of medical professional societies, and finally by the World Health Organization. And you see how often the patient is really mentioned and in the focus. Here's a little a few studies that look at the outcomes of PBM. This is an interesting one because it looked at the effect of ultra short-term management of patients with iron deficiency and anemia and cardiac surgery. The time between admission and surgery was 24 hours or less. And so the primary outcome with PBM in a very short time frame was would PBM alter the number of RBC transfusions during the first 7 days? The median of units given in the placebo group was 1, and the treatment group was 0. And you can see that hemoglobin level, reticulocyte hemoglobin content, and retic count on post-op days 1, 3, and 5 as secondary outcomes increased significantly. Very interesting new study, a propensity matched cohort study of IV iron versus RBC for pre-op iron deficiency anemia. It was 77,000 patients in each arm. And you can see these were iron, no red cells, and these were red cells, no iron. You see a 37% reduction in mortality in the iron group and all the other outcome parameters. And interestingly, even post-op hemoglobin was significantly higher. You see the p-values here in the iron group. Or here, another modality, pillar 2, viscoelastic testing. This is the so far the largest systematic review with more than 20,000, no, with 21 studies and 8,900 participants. And it shows a 36% reduction mortality with the use of viscoelastic testing. Similar good results for acute kidney injury. Here is a reduction of 47% with point-of-care testing. Or here, a paradigm shift in trauma management in the University Hospital in Zurich from 2005 to 2007, traditional management, and then the second period over 3 years, goal-directed coagulation and transfusion protocol, TXA, primary whole body CT, restrictive fluid therapy, permissive hypovolemia, hypertension, damage control surgery, and here's the results. Massive reduction in blood components, red cells, FFP, and platelets. Also, fibrinogen went down. TXA, a massive increase of a very non-expensive, non-costly drug. But most importantly, we saw a significant reduction in ICU hospital lengths of stay and ventilator support. And we saw a significant reduction in day 1 mortality and in-hospital mortality. Sorry. Here's the program that Vernon spoke already about, the Australian PBM program that began with the lowest red cell transfusion rate of the Western world. And you can see when the program started, it was 30 per thousand inhabitants. For Western Australia, was 37 in the rest of Australia. At that time, the United States was at about 60, and I think Denmark at about 70. And during the implementation period, we came down to 19, ended up 2/3 below the US. This was done with a one-time investment of $4.5 million. And what is so interesting, this was really applying the entire bundle of PBM, all 3 pillars, consequently for all elective and emergent patients. And you see the reduction of the various components. You see some key program indicators like the anemia rate pre-op was very low. The remainder of 14% was mainly for urgent emergent cases. Retrospectively, the hemoglobin dropped down to 7.3. There was no numeric threshold. It was more physiological, but in retrospect, the application of it led to, obviously, this hemoglobin level. Single unit transfusion dropped significantly, but most importantly, the patient outcomes. The study was showing an association of mortality decrease of 28%, hospital-acquired infections 21%, myocardial infarction, stroke 31%, and the hospital lengths of stay saved about 70,000 stay days. And given the $4.5 million investment versus an $18.5 million reduction in costs and hospital acquired acquisition costs, sorry, and more than 80 million in activity-based cost is an enormous return of investment. Here's a study in a very poor country, in one of the poorest countries, not with the whole PBM bundle, but with a small bundle on pillar number 2. And it was a 3-step treatment strategy with misoprostol, followed by an intrauterine condom tamponade when the bleeding was persistent, and a non-inflatable anti-shock garment. And with a training and some lay health workers and community health workers, they achieved the primary postpartum hemorrhage case fatality from 5.5% to almost 50% less. Quite impressive. Or another study in poor countries and low-income countries, including African countries, is the emotive study, again on postpartum, on the detection and treatment of postpartum hemorrhage early. It was also mainly a bundle of pillar 2 modalities. And what you see in these 50,000 patients, more or less in each arm, intervention and usual care arm in this randomized controlled trial, you see that the primary outcome, which was a composite of severe PPH, laparotomy for bleeding, or maternal death from bleeding, dropped significantly by 60%. Here you see, interestingly, also the usual care group improved. You see the Hawthorne effect, but much more the intervention group in terms of the primary outcome. Then the secondary outcome, we see here a detection of PPH was significantly improved. And the adherence to the treatment bundle, secondary outcome here, PPH dropping by, what was it, 49%, and the severe cases by 61%. And further down, the blood transfusions for bleeding dropped by 29%, and the mean blood volume lost dropped from 380 mL to 225. So you can see this is interesting. This is another piece of economics. Healthcare expenditures per capita in the world, with Qatar somewhere around $90,000, US somewhere around 62,000, and then you see Niger. We saw the study here, and we know studies like the one from Johns Hopkins, greater than a 7-fold return of investment of comprehensive PBM with equivalent or improved outcomes. It is doable, feasible in all parts of the world, regardless of the resource constraints. And that's why we're saying PBM improves outcomes for millions while saving billions. So what is holding up? It's basically culture and behavior. And in the policy brief of the WHO, this is echoed. Despite the evidence and the ethical imperative to implement it, culture and behavior and existing medical dogma are the main obstacles for the implementation, and the longstanding position of transfusion as the usual care. This is why the policy brief emphasizes over and over again that PBM addresses the problems of anemia, bloodless, and coagulopathy. It's not about transfusion, it's upstream. It's what's happening before you even consider a transfusion. And then they took verbatim the global definition into the policy brief. And here's the call to action. And in that document, it's already mentioned that there will be another document. And here the Secretariat of the World Health Organization, after publishing the policy brief, announced a technical guidance on the implementation of PBM is being prepared. And this is where my colleagues and I are working on, including, by the way, also Vernon in the larger group. Here's the steering committee. but some names you might be familiar with. Tasked with the policy brief, and then we also added Shannon Farmer from Western Australia, now on the development of the implementation guidance, and this is supported by at least 100 international PBM experts. And this comes now to the end of my presentation. When WHO approached us, they said, we want you to help us with the implementation of PBM. They showed us this action framework to access to safer blood, or safe blood. And they gave us 6 strategic objectives and said, please look after number 4, the effective implementation of PBM to optimize clinical practice of transfusion. And we said, yes, we are ready to help you, but we have a gross misunderstanding here, or misperception. We are not doing this to optimize clinical practice of transfusion, but to optimize patient outcomes, or as we say now, blood health. Because this is PBM, whereas all the other activities should be under the flag of optimal blood use. And so we showed the WHO that this is an important distinction, because PBM aims at the etiology specific of the ABC problem, whereas the right-hand side is aiming at basically thresholds. Left is the patient focus, right is the product focus. Left is good clinical practice with prevention, diagnosis, therapy, and follow-up, and with the big aim, blood health. And on the right-hand side, we have a monotherapy, often, unfortunately, without diagnosis. And this is why the WHO also says that taken together, these 2 blocks represent one of the world's biggest but largely preventable modifiable risk factors, yet greatly underestimated public health burdens. So the only way to crack the triad is the 3 pillars. We are working now on the guidance to implement this whole concept, and it has 2 focus groups, 2 audiences, health authorities and single healthcare organizations. It is a 3-step program, so much we can reveal already. Phase A, preparing the national healthcare system for PBM, driven by the 3 Ps, promoting blood health through PBM, protecting blood health through PBM, and preventing disease through PBM. It's an 8-step process, followed by conducting PBM pilot projects, driven by the 3 E's, evidence, economics, and ethics for and of PBM. It's a 6-step program. Once the pilots under the auspices of the government with the shared responsibility of public health authorities and health organizations, we're looking at phase C, which is the national rollout, with the responsibility going back to the public health authorities. So coming back to our friend William Harvey, he made a good start. However, we found that blood is the most neglected organ. And to end this presentation, let's think once more about blood health, the optimal function of the blood's individual elements and their associated interactions with all other organ systems. You as clinicians, do you treat the patient's blood as the body's liquid organ, or just as a commodity? Do you treat it with the same respect as any other organ? Do you help your patients to do so? Do you preempt iron deficiency and anemia? Do you promptly manage blood loss and bleeding? Do you proactively manage acquired coagulopathy with bleeding? In other words, do you manage the patient's own blood, or do you just replace it with someone else's? Thank you for your attention. I said 38 minutes, it was 38 and 52 seconds.
That is, I think, a combination of Austrian and Swiss precision. Axel, thank you so much. Wonderful stuff. And want to encourage everyone again to add your questions to the chat box. I was wondering, from a philosophical point of view, let me get my video on here, why we look at blood, as you say, a liquid organ, differently from solid organs. Is it because we think we can leave the tap running because we've got an endless supply with a factory that will always just produce? Have we become used to that as a world? is the problem just too overwhelming? Looking at your initial slides, that people just throw their hands in the air and they say, well, I'd rather not think about it. It's too much. Why do you think, you said the behavioral parts is a major component. Why do you think psychologically do we as humans or as doctors not take it as seriously as we should?
I can only speculate because we don't really have data on what drives physicians, clinicians to do that. But what we see is clearly the ongoing emphasis. There's a paper from Roberts and colleagues, again in the Lancet, I think, where they estimate the world's total consumption of all blood components, so platelets, plasma, and red cells. I think it's about 200 and some million. And the authors conclude just one thing: we need more blood. Right.
Yes, I remember that paper.
So
quite recent.
So nobody thinks about the upstream problem, and I think transfusion is grandfathered into the system. It was, and as these early publications, 1917, 1936, 1942, they already say, well, be careful, don't become complacent, don't think. The one paper spoke about the convenience of the blood banks, right? Arya Shende says, when you want to transplant the liver, a lot of paperwork, right? When you want to transplant the liquid organ, you just need a pen and an A4 sheet or 2 clicks in your hospital system, and you get the stuff.
Yes.
And it is viewed as a commodity, and that's why we think we started with the blood facts in that presentation to make clear what a unique fluid this is, and what we read from everyone's blood. I remember James Isbister when he started. He told me that story, I think 60 years ago, when he and his young colleagues took a pint of their own blood, stored it for 42 days, and reinfused it to themselves, and looked at the parameters. Wow. And one of his colleagues had to be hospitalized, and you had the blood counts and the CBC of an intensive care unit patient, right? So. We are, I mean, I think that the term diagnostic error is not strong enough. In fact, given all the evidence, it's negligence. And that is then a medical legal problem, right? So I think the implications are big, and it's time to rethink and to really appreciate all the evidence that has been presented over the last 20 years and to change practice.
Thank you. I see we've got a comment here from Rita Govender saying, thank you for very enlightening talk. Thanks, Rita. And then Sharoch, nice to see you. Sharoch says one of the problems was that the 2011 WHO guidelines were very conservative regarding ferritin threshold to diagnose iron deficiency and iron deficiency anemia. And if you want to comment, otherwise I will also. Yeah,
I think this is your turf. I mean, we know that ferritin is not enough. We need TSAT at least, and I don't know. Yeah, I think it's better.
I think Sharoch's absolutely right. I mean, that is such a key point, and I think one of the most important issues here is the inadequacy of the foundations on which we base our cut-offs of ferritin and other markers. And there's been this recent paper in the Lancet discussing all the unreliability of the old cut-offs, because the population in which it was studied were actually, they did not include people at risk of iron deficiency. So you actually started off with the wrong populations. The second, I think, major problem has been that the gold standard being a bone marrow to look for iron staining in the marrow was not done in most of these studies. And we've got something in press that will be published in Pathology soon, where we actually looked at bone marrows and correlated that with iron studies in a group of patients, the group that gives us the most difficulty, patients with HIV, infections, inflammation, cancer, and the results were very interesting. So that will be out soon, but will also hopefully help us have more evidence-based answers in how to diagnose iron deficiency in that group. And like you say, Sharaf, apart from the WHO, I think the WHO's criteria from 2011 were actually better than what we have in South Africa. Even worse in most of our labs. Some of the criteria used here, I think some of the labs have now come to the party and have improved it, but we're not there yet.
Yeah, but Sharoch is a few steps ahead, because what we see and what we saw in Europe, and I think in most hospitals in the United States, although each anesthetist and each surgeon had the lab values and saw that his or her patients were anemic, this didn't cause any reaction. They just accepted the hemoglobin as it was and didn't see it as a problem, as Ari always says, an innocent bystander. And the patient landed on the operating table. So they did not even consider a ferritin test or looking at iron deficiency. The fully established anemia was not a reason to do anything, right? And this is where the thinking needs to change.
Yeah, and I agree. And I think one of the top centers in Canada has just published exactly the same a while back in pregnancy, that the vast majority of patients in pregnancy are not tested for iron, despite a very high prevalence of iron deficiency in that group.
And the next problem is the gender disparity. You know, I don't know what your opinion is, but 12 grams for women and 13 grams for males is arbitrary. You know, if we had 13 for everyone, now the 2.9 billion go up to, I don't know, 3.3 billion.
That's right. And I think there's evidence for that. I mean, we've got the data from cardiovascular surgery showing increases in mortality already, starting with HBs between 12 and 13, not necessarily below that. Marius Kutsia asks, any suggestions for improving the culture of transfusion committees? Yeah, the terminology.
Great.
Versus patient blood management committee.
Absolutely. That's the first psychological step, right? If we ask the colleagues, do you want to start the management upstream? Then the first thing is to rename it and to invite as many representatives of departments that potentially benefit from PBM, or their patients would benefit from PBM. I saw that funny question, or funny psychology. That was a nice one. I understood that all disciplines, this is from Rita, need to leverage blood health with the exception of psychiatry. That was probably a bad joke from me, because she says, would symptoms of anemia perhaps not exacerbate some conditions like mood disorders? And I think you have comments on it.
I support that. You know, actually, I'm going to talk about that tomorrow a little bit. Because it's interesting. What I'm talking about tomorrow shows that iron deficiency in the absence of anemia actually cause mood disorders, anxiety, depression, all sorts of things.
Yeah.
You don't have to be anemic to get any of that. So thanks, Rita. That's a great.
I'm sorry, Rita. Yeah, I should not have said that. But I had the others. I said ophthalmologist, right? And there was this funny presentation. My good friend Angel Caratid from Spain, who has now an amazing PBM liver transplant program. The data will be out soon, and one of the slides he showed, since his program is running, that the ophthalmology department of the General Hospital in Mexico City ordered more blood in 1 month than the transplant program. So transplant uses very little transfusion those days in that program.
Elvan, who's currently working in Ireland and very involved, she's doing incredible work in a rare disease called hereditary hemorrhagic telangiectasia, or HHT, otherwise known as Osler-Weber-Rendu syndrome. And she's been quite involved with PBM, also speaker tomorrow. she says maybe to start small with a PBM champion in your setting, informal discussion, prompts thinking. So true. You need one person in a hospital, it doesn't matter how small, to start doing something. And you can change massively outcomes of people.
I fully agree. I was asked yesterday, what is the disease group or patient group you should start, and I said, don't come from that end. Identify where in your hospital sits the champion. If it's the quality and safety manager, you start probably from a totally different point. If it's a surgeon, like we had one, Mani Estioko in California, cardiac surgeon who became one of the most fervent supporters of PBM. Other hospitals in the ICU, and other hospitals in the anesthesiology department. Next hospital is the hematology department. So I think there is no rule. The only rule is find a champion.
Sure.
And make a leading coalition with adding more. And this is, in fact, the first steps of what is called the Cotter model.
Yeah.
Totally
true. And then Jenny has got much experience in the obstetrics obstetrics area, specifically with treatment of iron deficiency over many decades, and also a champion in her own right. She just mentions the risk again of people, patients presenting with non-major hemorrhage, for example, ectopic pregnancies, and they just give blood and put patients into pulmonary edema. It's interesting, Jenny, there's a paper out published this year, a few months ago, from the European Hematology Association and the Iron Expert Group, the SWA Iron Expert Group, which I thought was really interesting, where they emphasize many of the points made today. And these are hematologists. I didn't even recognize names in the PBM world, but they were emphasizing patient blood management. They were emphasizing the fact that the patient should not be transfused unless there's cardiovascular compromise, which was quite a statement coming from the EHA. So published in the Hemisphere, which is the journal of the European Hematology Association. I want to move to Mike Henry. Mike is a man with a lot of energy and action and ideas, and very active on our group. Mike, nice to see you.
Thanks very much for those kind words. Prof. Hofmann, I've heard a lot about you. First time I've heard you speak. You certainly didn't disappoint. I'd just like to comment about this whole issue of the culture that we face in the entire medical profession. And if you think, Mark Twain once said, apparently, I will not allow my schooling to interfere with my education. And as a medical student and a doctor, I think that one of the biggest problems is this mantra that blood saves lives. I can understand why you need it to get the public to go and donate, because lots of blood programs struggle to get enough donors. But for the medical profession, don't you think that's counterintuitive? Shouldn't we rather be saying things go better with your own blood? Or blood saves and takes lives, treat with massive respect. And I know that in all my years as a doctor and having worked in the hospital at Livingston and Port Elizabeth with lots of trauma, etc., the biggest fear that medical practitioners have is the responsibility of perhaps losing a patient because you didn't give them blood. So if you do it to cover yourself, that's why you mentioned most blood transfusions occur at night so that the doctor can sleep better. And they do it because of that training that was inculcated, that blood saves lives, that if you don't, you somehow harming the patient. And as you've mentioned, it's going to be a massive task to change this. And so I want to say something that might sound controversial. We all know that Jehovah's Witnesses don't want blood. And Jehovah's Witnesses can be regarded by the medical profession as a pain. But I'd like to appeal to everybody on this talk to, next time a Jehovah's Witness walks into your ward, hug him and say, right, you don't want blood. I want you to help me get over my schooling and my fears, and I want to use all the things that I've heard about and see whether they work. And I think that the doctors that do that are the most likely to overcome this problem of the schooling that they had as medical students. Any comments on that?
You know, first of all, I can echo everything you said. I mean, in every point you are right. What comes to my mind first, especially in the United States, where the lawyers drive the business, it is defensive medicine, right? So we know for a fact that many, especially junior doctors at night, they would give the transfusion when the nurse says, hey, the patient's a bit pale, and he just doesn't want to get into trouble. He says, this is a standard of care. He reads the transfusion guidelines, and there's nothing about the upstream management that we talk, you know, the A, B, and C problem. And I think it's, when you say interfere with the schooling, when it comes to that very point, there is no schooling. There's a total blank and this is why blood has been treated with disrespect, has not given the attention, and has not given the attributed value that it actually has. And even with the hematologists, you know, they look when something goes wrong with the blood, but they don't look at, is there enough blood? Like, you know, is there enough bricks to build the blood? This is not the core business of the hematologist, correct?
In South Africa, it actually
is. Because we have you, and we have you are probably that's probably the reason. That's probably the reason
we're forced to.
Yes,
so few. We're forced to look after.
Yeah, but you're an island of PBM. That's a beauty in this whole story, you know. And you said 7 or 9 years ago you started, and that's amazing what has happened in this country. But Max, again, I think. You know, culture has changed for breakfast. You know that statement. And that's what we see with this whole problem of preconceived ideas. Or Timothy Hannon says blood is surrounded by myths, habits, behavior, anxieties. And I remember that Maitland study with severely anemic children in Africa. That was New England Journal of Medicine 2019 or so, when they said we cannot expose children to these low hemoglobin levels because of a lack of blood. We have to raise the threshold from 4 to 6 grams. Then they did the RCT, and they found no difference. You know, the raising from 4 to 6 didn't bring anything other than emptying the blood bank. And just recently, I think this is a paper by Mullis in a Journal of Orthopedics a month ago. He did a randomized controlled trial comparing 5.5 grams as the intervention group versus 7 grams. And guess what? The 5.5 grams group is better than the 7 grams group. So we have established these magic numbers somehow. They are grandfathered into the system, and nobody wants to move them. All these trials, as you've seen, the meta-analyses where the restrictive groups overlap with the liberal group. Nobody dares to step outside of these boundaries, although physiologically there is no reason to do the contrary. Jens Meyer yesterday at the anesthesiology conference gave a talk about where is the actual where are our physiological limits, you know, and he says it's at 3 grams. And there's a lot of interesting literature supporting this. Yeah, there's a lot of learning and a lot of schooling and mentoring and teaching and studies, and you as the individual physician, you have to get out a little bit of your comfort zone, apply PBM, start with the low-hanging fruit, look at those patients who have 500 milliliters or more of blood loss usually, and start to apply the 3 pillars and have a look at the outcomes. I think local data might be what convinces the most.
And on that note, guys, thank you so much. There's so many wonderful comments, interesting questions, but we have to close. I just want to say something which is exciting in terms of local data. So there's really incredible things happening in South Africa. I think I mentioned to you earlier the Free State team, Marius Kutsie, Barrett, Petrolese, and the others, doing the patient blood management short course. There's one for doctors, there's for nurses, etc., technologists. Gary Soedwaards, who's an interventional radiologist in Cape Town, he also works in Gauteng, flies up and down, who's done more than 2,000 embolectomies of uterine fibroids with incredible success. And I think he told me of the 2,000, he needed 1 or 2 units of blood for the lot. The drape that was in the emotive trial is made in Stellenbosch by a local company. They also make a intrauterine balloon, which is used all over the world, both the drape and the uterine balloons all over the world. And I know that people from this company are very passionate about patient blood management. And we are also in the fortunate position that our blood services understand that blood has its role in emergency settings, but they're also incredible supporters of PBM. And I think in many aspects, we've got a unique and wonderful set of possibilities in South Africa. And I'm excited to see how this group will also take it forward. So with that, I'm going to say thank you, Prof. Hofmann, for a fantastic talk. Thank you for great interaction by the audience. Nice to see you all. Thank you to our iEcho University New Mexico team and iEcho India. The recordings are made available on the Gastro Foundation website. So thank you also to Prof. Chris Kassianides, who's been such a key player, the Gastro Foundation. Thanks to the sponsors, and a reminder that next week will be hepatocellular carcinoma for all of you interested in that topic.
Thank you, everyone, also from my side. Thank you again.
Thank you, Axel. Thank you, Vernon. Thank you.
Thank you. Bye-bye.
Bye-bye.
Bye.